Welcome to today's MESUD Learning Community webinar. Today we'll be hearing from Dr. Smita Prasad on addressing the specific needs of women with substance use disorder. My name is Bethany with CCSME and I'll be supporting today's webinar. Just a few quick notes before we begin. First, neither the presenters nor the planners have any relevant financial relationships to disclose. This activity has been planned and implemented in accordance with accreditation requirements and policies of the ACCME through a joint providership of the Hanley Center for Health Leadership and Education and CCSME. The Hanley Center is accredited by the MMA Committee on Continuing Medical Education and Accreditation to provide CME for physicians. The Hanley Center has designated this activity for one AMA PRA Category 1 credit. The opinions expressed by the speaker in this webinar are their own and do not represent the positions of the state of Maine or CCSME. Recording and live stream transmission of this webinar without consent is not permitted. We'll have a few minutes at the end of the presentations for questions and answers, so please hold all questions until that time and you can place them in the chat feature in Zoom. Slides from today will be shared in the follow-up email. And now I'd like to give a quick introduction to our speaker today. Dr. Prasad is board certified in family medicine and addiction medicine. She is an assistant professor of addiction medicine with the Tulane Department of Psychiatry. She is the medical director of the Louisiana Addictive Disorder Regulatory Authority Board and president of Louisiana Society of Addiction Medicine, and the current chair of the Physicians Health Special Interest Group for the American Society of Addiction Medicine. She is also the medical director for Long Branch Recovery and Wellness Substance Use Disorder Treatment Programs, and she provides outpatient addiction medicine services at the Tulane Addiction Medicine Clinic in New Orleans, where she is also the medical director. And with that, I will hand it off to Dr. Prasad for this presentation. Thank you all for being here today.
All right, thank you so much. Thank you for having me too. So today we're going to talk about the specific needs of women in substance use disorder. Of course, our needs are different than men's needs. And just to start, I have no financial disclosures or conflicts with this material. And anyway, so we're going to talk about women's unique addictions, trajectories, treatment, and recovery needs, how sex, like biological factors and gender, social factors interact in complex ways to create these differences. We'll look at the differences between the genders and, I hope to explain how attending to these differences can help improve outcomes for women with addiction, particularly substance use disorders. So, women have unique addiction, substance use disorder trajectories, treatment, and recovery needs. We are a separate breed from our male counterparts, and there are biological factors, as well as social factors that are represented by gender that interact in complex ways to create some of these differences. While we are studying them, we mostly study everything in medicine on men. Women usually are a small sect of what gets studied. So we don't really understand a lot of these interactions very well. So some differences that we might expect to see include how women respond to treatment. Women tend to be primary caregivers for their children or their maybe a parent, and so they don't necessarily, well, they have more barriers to entering treatment than men do usually. And there's also, we are more disposed to have comorbid psychiatric illnesses, especially PTSD, depression. We have high rates of depression, anxiety. And we go through menstrual cycles, most of us, and the different reproductive phases that can actually play a role in substance use. And then again, like I said, the caregiving responsibilities, the associated stigma with the disease of addiction. There's a stigma too for being a woman in today's society still. So, it could be a scary thing for a woman to get treatment, to get help for their substance use disorder. But if we can engage women and just be more attuned to what some of these differences are, we can definitely improve outcomes. All right, so this is an example of, let's see, the differences between like sex and gender. Um, it's the system's biologic perspective, and in this schematic, like sex equals the genotype. So that's like kind of what's in the genes, the DNA, what's coded, and then gender is how um, it's expressed, the phenotype. And unfortunately, in this current presidential administration, they're really trying to limit how that phenotype is um, expressed. And for this talk, we're just going to kind of keep it simple, male, female. And so let's see. And this is just kind of a schematic about how all that interacts. The environment influences kind of how our genes are expressed, and how that phenotype might be expressed. Whereas the genes, the sex part may influence their environment. I don't know if that makes sense, but females play a different roles in some family units than in other roles. Males may be a son, but they're having to be the father, and just kind of influences their maturation and other things. So it's all kind of plays into it, and there's differential environmental opportunities for gendered differences. There can be what's similar behavior really is the sex, but in sex it's a dynamic but stable biological trait of organisms that kind of act as a multi-layered biological context, and this way kind of determines the individual and their characteristics, and then how they respond to in the environment. There can be generational change and national differences, and it's complex, as you can see, complex. Um, and so sex and gender can influence drug consumption, what drug is consumed, how it's consumed. And this is just a schematic that kind of represents that sex and gender-based influences on drugs consumption. I mean, that we have different pharmacokinetics, like if you think of the way alcohol is metabolized, drugs are maybe bioavailable differently. Our genetics may result in different effects of the drug. So we know that sex and gender play a role in all of this, and clinically related phenomena, how it's consumed and what we're seeing. And okay. And then of course our brains are different. Um, we wouldn't don't have the same brains, but our brains develop differently. There's differences in the neurotransmitters that are available in the brain. There's differences in the concentration and the receptors, kind of things like that. And we know that there are sex differences in the brain's mechanisms that mediate reward and addiction. And some of these sex-dependent traits can contribute to differences in both your risk to develop addiction, particularly substance use disorders, also resilience to how someone uh, deals with, sorry, their addiction, and then behavioral manifestations, and each of the three main stages of addiction, which doesn't say on this schematic, but the phase of addiction is like the binge intoxication stage. Person's using the substance, they're getting euphoric feelings. Then as the drug wears off, then they're getting this withdrawal phase. Their affect gets, negative, maybe irritable, restless, discontented. And then they start to want to seek the drug, and they're looking for, they get preoccupied with finding the drug and getting the drug and using the drug. This is another schematic just showing that our brains are different organizationally, and these contingent mechanisms, they just lead to sex differences in how dopamine signaling occurs within our limbic system, which is very important for reward, um, mediates reward. And also, we see hormonal differences like estradiol increases dopamine in the striatum of female brains only. So this is just another chart that shows the differences between sex and gender. I think this is benzodiazepine use in the United States. This came out in 2015. That light circle, the top line represents women. And on the x-axis is age, is increasing age. On the y-axis is benzo use, percentage of benzo use. Um, and then the men's, that darker square line, and you can just see there's a marked difference between men and women and the use. This is the prevalence of benzodiazepine use in 2008. So women like their benzos. So we see differences in active addiction too. In particular, I overwhelmingly treat more males because more males seek help in our society. So, but there are some sex differences, like again, reproduction, which are qualitative, quantitative, how we respond to smoking cessation medications is a way that is different than in men, and we're going to talk about that at the end. Some of these sex differences are like convergent, or they're converging. Unfortunately, our rates of alcohol use between men and women are becoming increasingly similar. Um, and some, again, I know I had mentioned like our populations differ. More women tend to be caregivers. Um, and some other sex differences that we see in the stages of addiction, those three stages that I had mentioned, how we obtain our substance uses can be different. We may escalate to use much more rapidly, or there's differences in that. Um, Maintenance, how we maintain sobriety or use may be different. Withdrawal effects can also be different. And then relapse rates can be different as well. So there can be lots of differences. Oh, I don't. Okay. And again, this is another graph. It came out of alcohol research in 2020, but showing the differences in alcohol consumption and showing how it's males and females, this convergent pattern. The top dark blue squares, that's males. The line below it is the circle and black circles, and that's females. And the x-axis is the year, and you can kind of see from like 1976 to 2018. And then that's that superimposed picture, but our rates are becoming more similar. And the top is the percentage of people, 12th graders, that drank in the past month divided by gender. And then the bottom there is like how many times they got intoxicated in the past month. So yeah, differences in active addiction. There are many mental, physical, and social differences between men and women. Women often report that stress, negative affect, and relationships precipitate initial use. I hear a lot well, I started dating this guy and he was using X and he gave it to me, and then, that's how I started using it. Um, and what we know is that women develop substance use disorders in less time than men. Um, and I don't know, use disorder is defined by DSM-5, which is, like psychiatrist book, but it gives specific criteria about the severity of the substance use, and women tend to have this pattern where they develop more severe problems like tolerance, withdrawal effects, negative consequences in shorter time than men. And women experience different physical effects of substances also. Some of you may have heard of the telescoping effect. This is, of course, due to hormones, but basically, what it says is that women, we start to use substances later in life, um, at a later age, but then we develop lots of the sequela, the problems, complications much sooner, much faster, um, than our male counterparts. And women tend to will get into treatment sooner than men. What we're seeing is the rates of liver transplant. And I know this is not just in Louisiana, where we do have the highest rates of liver transplant, but in other parts of the country, the rate, the group whose prevalence is rising, needing alcohol, that have alcohol liver disease and need transplantation, are young women, like around in their 30s. That's growing. Females are more sensitive to the positive reinforcing effects of drugs compared to males, and they acquire drugs. They're able to get their drugs faster than males and administer them faster than males, which not necessarily a good thing. It may be because they are doing dangerous behaviors to get their substances. And males are also maybe more freely giving them substances. But some other differences that we see, like I said, vulnerability to relapse, that's mediated by some of these different neurotransmitters, and vulnerability to relapse. Did I just say that? I'm sorry. Motivation, craving, all of that is mediated in our brain and can be different between men and females. So some other differences: women are less likely to use almost all types of illicit drugs. So that's good, but rates of dependence on illicit drugs and alcohol is lower. What we do see is illicit drug use is less likely to send women to the emergency room. Women are less likely to overdose, simply because less women are using illicit substances. But women may be more susceptible to craving and relapse, and not really be able to tolerate the craving and might need treatment sooner. It's talking about alcohol. Females ages 12 to 20 have slightly higher rates of alcohol misuse and binge drinking than males of the same age group, but we are seeing that converging pattern. Chronic alcohol use is more likely to affect a woman's health, even if she drinks less alcohol for a shorter time. And what we see are death rates from alcohol-related deaths from suicides, accidents, cardiovascular disease, stroke, and liver disease are actually 50 to 100% higher for females than males, which is scary. And of course, we have other unique health risks. Alcohol contributes, use contributes to increased risk of breast cancer, increased risk of having unprotected sex that can lead to unintended pregnancy or sexually transmitted diseases, infections. And of course, women tend to have an increased risk of becoming a victim of violence or sexual assault compared to men. We metabolize alcohol differently due to differences in our gastric tissue activity, which leads to higher blood ethanol concentrations in women comparable to men, even if we drink the same amount of liquor. Women require less alcohol to become intoxicated compared to men, which I think I had stated. So some other differences that we see in behavior due to alcohol. I'm not going to read through all of this, but oh, let's see. Acute alcohol injection here says increases preference to a large, uncertain reward in males. Females don't usually show that preference. Men exhibit larger levels of alcohol craving in response to cues than women do, whereas women tend to have to work harder to resume using after 2 weeks of abstinence than men. So there's just some differences in behavior and their affect that this is talking about. And we're more sensitive to drinking cues, sex differences in positive and negative reinforcement drinking. So men tend to drink more when they're positively reinforced, like they're celebrating with their colleagues. Maybe they get a promotion, and so they will drink more. But women tend to drink more when, like, for negative reinforcement. Um, Maybe there's a bad breakup or they didn't do well on an exam. But women tend to drink for negative when negative things occur. And this just encourages certain behaviors by removing or avoiding an unpleasant outcome. That's what we'll use alcohol for. And women and males use alcohol differently for coping. Females, again, we will use alcohol or other substances to treat depression, anxiety, if we're bored, a pain, emotional pain, physical pain, insomnia. Um, we also tend to drink more to cope with, where cognitive disturbances like expectancies, maybe we have like lower self-esteem, incapable of making decisions or having trouble with decision making. But we tend to drink more for emotional things. Whereas guys, again, which is the bottom schematic, they're drinking more because of social pressure. Maybe they're watching a football game. But they drink more to like network and to fellowship. Um, and then again, they tend to drink more in a response to craving, reward seeking, um, more like, I guess, high risk situations there. Tobacco, there's differences in tobacco use. Women smoke fewer cigarettes per day than men. They tend to use cigarettes with lower nicotine content. So like those Marlboro Ultra lights or lights. And interestingly, women do not inhale as deeply as men. And women may smoke for different reasons. Usually it's stress and anxiety, which results from withdrawal, and more commonly seen in women, of course, is these when in the withdrawal state, they tend to get more anxious. Women using oral contraceptive pills may be at an increased risk of blood clots, having a heart attack, or maybe a stroke. And women are less likely to quit and more likely to relapse on smoking than men. This is just kind of showing some differences in the brains between dopamine levels. So the red is our female smokers. Dopamine's the pleasure reward neurotransmitter in the brain. So women tend to have blunted dopamine release when they use tobacco, whereas males tend to have just a normal dopamine release or higher dopamine release. So they get more of that euphoria when they smoke, and so it's more rewarding to them to smoke. Cannabis, lots of differences between males and females in terms of cannabis, and even with the medical cannabis, which I have my own opinions about. Louisiana medical cannabis is legal and it's very easy, in my opinion, to obtain it at dispensaries. But anyway, fewer females tend to use marijuana than males. And what we see is that in males, it does tend to impair uh, it impairs spatial memory in women more than in men. But males, again, respond more with because of the dopamine, increased dopamine, they tend to get greater highs than women. And then teen girls may have a higher risk of these brain structural abnormalities with regular exposure. We know the adolescent brain is very sensitive to cannabis, and we don't know in all the ways that cannabis affects the adolescent brain, but there's going to be differences that we see in the endocannabinoid system and how that develops based on whether a gender. And then we've seen in animal studies, that female rats are more sensitive to the rewarding, pain relieving, and properties and activity altering effects of THC, which is the predominant psychoactive component in marijuana. And again, this is due to the effects of sex hormones, and as I mentioned, possible sex differences in the endocannabinoid system in the brain, how we experience pain and pleasure. Some other similarities. What we see in both men and women that use cannabis and have a cannabis use disorder, they are at least have one other mental health disorder. I think that that's probably anxiety. I hear a lot of people say that they use marijuana because of their nerves. Anxiety is definitely a big one, and low rate of seeking treatment. And that's true. I don't have very many people that come in that have a primary cannabis use disorder. And I just think it's because cannabis use, this doesn't, you may not see the direct results, consequences of cannabis use, like you do with some other substances, like, opioids, you can overdose, um, alcohol, DUI, but driving and crashing. But you can also see increased rates of DUI in Colorado. So, and I think they had legalized cannabis many years ago, one of the first states. But some differences in cannabis use disorder is like men tend to use other substances too. Mostly like I see a lot of cannabis use with alcohol, cannabis use with opioids. They usually tend to be more polysubstance users, and have more severe substance use disorder. They tend to have a lot more antisocial personality disorder, where women, excuse me, the women that use cannabis will have more of these panic disorders, anxiety disorders, and of course, they can develop these disorders more quickly than males. Um, but yeah, women, more panic attacks and more anxiety. We see differences too with stimulants. And here I'm talking about cocaine and methamphetamine. Human and animal studies suggest that women may be more sensitive to the reinforcing, rewarding effects of stimulants. And of course, this is possibly maybe due to hormones, particularly estrogen, which I find very interesting. Females are quicker to start taking cocaine and taking it in larger amounts, um, which I actually have seen recently a lot more younger females coming in with cocaine use disorder than men, which I find interesting. These girls are like in their early 20s using cocaine. And women may be more sensitive to cocaine's cardiovascular effects compared to men. Um, Female cocaine users less likely to exhibit blood flow abnormalities in the frontal regions of the brain. So, the prefrontal cortex is very important for decision making, executive functioning. Uh, so, I guess that's why we maybe can use and stay more rational. But females less likely to have problems in that region from using. Um, Women report using methamphetamine to increase energy and decrease exhaustion more so than men. Women were working, uh, we have to attend to our house, childcare, family responsibilities. So women tend to be go, go, go. And I too drink a lot of caffeine. But that's why women will tend to use stimulants, and they will start to use methamphetamine at an earlier age than men, which I find interesting. Women become more dependent on methamphetamine than men do. I don't see a whole lot of people in general, even though meth is a really big problem in the parish that I'm in. But I don't see a lot of people with methamphetamine use disorder, which is kind of sad because they can be functional while using their substance of choice. Um, and women are less likely to switch to another substance if they cannot obtain methamphetamine. So they can't get the meth, they won't try something else. Whereas a guy might be like, I can't get meth, so I'll drink alcohol or I'll do whatever. But this is just showing the sex differences, gender differences in the motivations for methamphetamine use. Orange, I think, yeah, is the females, and the blue is the males. Um, Males actually reported here that they use meth to work more, um, whereas women tend to use uh, meth more to lose weight, um, maybe a little more preoccupied with their weight. Men, especially, we see in homosexual men tend to use meth to I don't know, enhance their sexual intercourse. Um, Stay awake is another here. More men tend to experiment with methamphetamine than women. But again, here, this big one, women using for energy, uh, because their friends use, and just for fun. So those are some differences. And all right, now MDMA, which includes ecstasy and Molly. So researchers showed that MDMA creates stronger hallucinatory effects in women. And there is some evidence to suggest that in women that use infrequently, they are more likely to feel depressed a few days after last use. I mean, it just depletes your serotonin levels, ecstasy, but they're more likely to feel the effects of the drug. We know that MDMA has been associated with urinary retention and neurogenic bladder. I think that's just both the same in males and in females. And in both, but it's not widely reported, can cause untreated untreated hyperthermia from MDMA use can result in life-threatening rhabdomyolysis, which protein breakdown, which can be really bad. Women are more likely to die from hyponatremia caused by excessive water intake, which like MDMA just makes you very it makes a person very thirsty, so they're drinking a lot of water. And this causes like drug-induced alterations in how our kidneys excrete water. That can result in severe cases. Severe cases can result in brain swelling, mental status changes, seizure, coma, and death due to the way the water shifts from the serum compartment to intercellular spaces. And almost all cases of death from MDMA causing hyponatremia has occurred, that's documented in young females between the ages of 15 and 30. So it's crazy. All right, so heroin, yeah. Compared to men, women who use heroin are younger, likely to use smaller amounts and for a shorter time. Less likely to use intravenously and are more influenced by their sexual partners that use substances. We were seeing rates of IV use decrease among both genders, which is good. And honestly, I don't see a whole lot of heroin anymore. Mostly it's fentanyl. But these are some differences between men and women. Prescription opioids. Now, some studies indicate that women are more sensitive to pain than men. The emotional pain, musculoskeletal pain, nerve pain, and they're more likely to have chronic pain. And so historically, we've seen higher rates of opioid prescriptions, especially in women of reproductive age. I have heard so many stories, sadly, women some type of gynecologic surgery, maybe from polycystic ovarian uh, disease or fibroids or endometriosis, and they were given prescription pain medicine after their surgery, and they're just off to the races. And sad. I had one patient that started had to use fentanyl because she couldn't get the prescription pain pills anymore, and it was all from having a C-section and a hysterectomy. And women are more likely to misuse their prescription opioids. And by that, like to self-treat emotional pain, anxiety, stress. They find that the opioid kind of just helps relieve that for them. And women are more likely to take them without a valid prescription. During 1999 to 2016, overdose deaths in women from prescription opioid increase more rapidly. Uh, for women, like 596%. Sorry, the nurse is texting me. Almost 600% more. All right, anxiolytics and sedatives. This includes benzodiazepines, barbiturates, like Furacet, butalbital, and Z drugs, Lunesta, Zolpidem, which is ambient. Uh, Zolpidem and escapislone. I can never pronounce that one. But anyway, women are more likely to seek treatment for misuse of these CNS depressants than men. I think that is true. I've also anecdotally, I feel like they get prescribed um, these meds more frequently and like the different classes as well. Um, for different things, and they are more likely to die from overdoses involving these medications for mental health disorders like antidepressants. And then antidepressants and benzodiazepines result in more emergency department visits for men than women. So uh, differences in active addiction, again, so we see them in alcohol and benzodiazepines, which both work on the brain GABA A receptors. Differences in opioids, differences in cannabis, differences in cocaine and amphetamines, as well as in nicotine. We see differences and in processor addictions, or behavioral addictions, gambling, tend to be more males. Food and eating, sugar addiction tend to be more females. Video gaming, see it more in males. There's lots of ongoing research on the differences or on these behavioral addictions and then gender differences. So challenges of having addiction and treating addiction in women, really the struggles are pretty universal. Shame and stigma tend to be huge. Women more likely to experience physical or sexual abuse, relationship issues. May be more reason why may be a barrier to use. We have a very high divorce rate actually in the residential treatment facility that I'm the medical director of. Because by the time someone gets into treatment, they really have just, destroyed all of their relationships. But anyway, women may fear losing their children or may fear losing their partner. And sometimes they might need their partner's permission to obtain treatment. I had a mother who's a stay-at-home mom. She has 3 young kids. She was using opioids and benzos and all these other things. But her husband's a lawyer, and she just has to be a right time because he has to be able to take care of the kids. They didn't have any other familial support. Um, she had to wait until they could organize everything before she could come into treatment. So. Other treatment issues, lack of services for women. There are not many, at least in Louisiana, places that are exclusively for females. There are not a lot of facilities down here that take females, women and their children. But there are some sober living homes that are doing that now, but I'm not really sure of any treatment facilities around here. So the lack of services can be a huge barrier. Not the provider physician might not really understand how to treat a woman with substance use disorder, and may not understand or be sensitive to the fact that they may have a trauma history. There might be long waiting lists to get into treatment. And then again, childcare tends to be a huge issue. And of course, there's systemic issues, like lack of financial resources. There's not lack of clean, sober housing, poorly coordinated services, uh, lots of issues that we face in treating the disease. So, just like there are differences in active use of addiction, there are also differences in recovery. Um, Meaning like we respond to treatment differently than men. And that can be the medication effects, that could be in the type of care that we seek, or may be difference in effects of therapy, as well as mutual aid meetings. There's always more males in a AA meeting, well, not always, but very commonly more male dominant than females, and then a lot of females may not feel comfortable sharing all of their secrets if it's only men. So there can be lots of differences in that respect. But this is one that I thought was really interesting. Women respond to vernacycline, which, and I'm not supposed to say the brand name, but vernacycline is it's like a is an agonist on the nicotinic receptors and is very effective for treating tobacco use disorder. But this study found that women overwhelmingly responded better to varenicline than men did, and compared to placebo. So that's kind of cool. All right. Some other recovery issues too. Um, Comorbid psychiatric illness. Women may have more depression. And women, we see that this starts at, excuse me, the gender difference tends to start at age 12 and peaks at different times for boys, females and females. Their females tend to be more depressed in the adult age in the US than males. There's differences in anxiety and anxiety disorders. I'm sorry, I'm going to wrap up real quick. And then, higher risk of anxiety disorders, PTSD. Of course, women tend to have 2 to 3 higher lifetime risks of PTSD and greater risk of same trauma exposure. So being cognizant that there are issues specific to women in terms of recovery is really important. The impact of trauma may affect a woman's recovery. Women tend to be of 2 times the risk of lifetime of being stalked, having sexual violence occur to them, much like higher likelihood of injury by their abuser, and having long-term negative impact from this violence or stalking. So it's really important to be sensitive to those things. And again, considering trauma is really imperative when treating substance use disorder in males or females. But I've more female patients having more severe trauma histories. And I'll just this is some women-centered recovery support groups that might be important. You know, prolonged exposure, cognitive processing therapy, EMDR, they can be trauma focused and there's strong evidence for them. We find that psychotherapy is more effective than medications. And the VA here has some resources on PTSD that might be helpful. Seeking safety, it's a coping skills approach to help people attain safety from trauma and or addiction, present focused. I want to just get through this. I'm sorry. Of course, we have differences in fertility. Female substance users have lower fertility rates, and that's with if they've used any recreational substance use, they've used tobacco, smoking, cannabis, cocaine, alcohol. So, and then we have an increased risk of accidental pregnancy and active addiction. And nobody ever really thinks about how their substance use is going to affect their fertility. There are, issues with pregnancy and lactation that are important, and I don't really discuss here, but how to treat opioid use disorder in a birthing person is different. Well, it's not really different, but it maybe have more unique challenges than a non-birthing person. We don't have as much access to perinatal psychiatry. That is true. Pregnant women that are actively using don't tend to be very well accepted, not just in 12-step meetings, but in society. So, there's lots of differences in parenting and caregiving. We've seen historically, this Washington Post, crack babies. The worst threat is the mother themselves. Not that addiction is a brain disease and they might not necessarily be able to help themselves, but biggest threat is the mom. So uncertainty about impact of prenatal stress and substances on child development. We just don't know, and we see it a lot. With opioids, we're concerned for neonatal opioid withdrawal syndrome, fetal alcohol syndrome, so much stigma and discrimination. Every state has different laws. So fear of losing children. I think in Tennessee, like the woman had a miscarriage and got incarcerated. So have the right to be fearful. Again, recovery issues specific to women. We tend to have more burden of unpaid work, even if we're working and have an employed spouse. Tend to do most of the housework, childcare, long-term giving, and it's hard to balance recovery and going to a 12-step meeting when you have to do all of these things. Menopause can be a challenging time for women. They're emotionally vulnerable. It's physically challenging. And so women may use substances to cope with all of these changes. So just being careful about that is important. All right, I'm sorry, wrapping it up. So women, we have unique addiction, substance use disorder trajectories, treatment and recovery needs. And there are sex and gender differences that are interacting in different ways. We don't really know all of them and how it all works, but anyway, we respond differently. So, sorry. I guess take any questions, but I'll end it at that. I think if we are able to pay more attention to the differences, that we might have some better success. But it also would be helpful if our funding didn't keep getting cut and cut and cut.
There was a question about oh, and if there are more questions, you can email them to me and I can pass them on and we can answer them over email. But there was a question about innervation for women in the pelvic area, and that Anna was under the impression that that was still true because she's seen it raised in two separate webinars.
Okay, medical training for innervation of women in yeah. I don't even think really, at least when I went through residency, didn't even address addiction. So substance use disorder, and that's been out for 10 years. So is that a question? Let's see. Okay. Medical training. Yeah. But yeah, I think we do experience pleasure differently. Our brain reward structures, systems, pathways, that's the word, wired differently. So um
Let me see if there's any other questions. I
Oh,
did
yeah.
place the link to the survey, and also if you have any technical assistance requests or specific coaching requests, the link is there that you can request them.
Yeah, and Lucy's comment about noticing a decrease in fentanyl and an increase in methamphetamines and cocaine. I think that's a national trend. Overdose death rates from fentanyl were down. There's this fourth wave that's more methamphetamine, speedballing is what it's called. Bad news.
But thank you so much, Dr. Prasad, for your presentation, and thank you so much, everyone, for joining us today. Like I said, the links will be sent in the follow-up email along with the slides. And thank you so much for all this wonderful information, and we hope to see you all again soon.
Yeah, thank you.